if you could get the provider involved, obviously patient engagement would go way up. And you also now have the ability to maybe make some changes to the provider behavior, to the physician behavior, to the health system behavior in order to further affect change. Now, how has it worked? I think where it's happening, it has its impact. It's a fantastic thing, first of all, because the goal of improving outcomes, making patients healthier, and getting paid to keep patients healthy rather than treat them when they're sick, of course, is the right goal and has had positive impact.
Hello, everyone, and thank you for listening to another episode of our podcast. Today, I'm speaking with Rob Cohen, CEO of Livara Health. Livara is a company dedicated to advancing care in the musculoskeletal space through value-based management models. Throughout his career, Rob has consistently championed healthcare as a force for positive change, working to create solutions that elevate the standard of care in the industry. Rob, thank you for chatting with me today. I'm excited to learn more.
Thank you for having me. Appreciate it.
Super. So before we dive any deeper, could you take a few moments to tell us a bit more about yourself?
Sure. I've been in healthcare for a little over 20 years. Earlier in my career, I was not in healthcare. Did a little bit of consulting, a little bit of startup work in the early days of the internet boom. Worked for Disney for a little bit. And so I bounced around doing a few different things before I fell into healthcare, actually, while I was in business school.
And what was your first gig in healthcare?
Well, I was engaged by WellPoint while I was in school. My partner in the startup that I started had actually been engaged, and he pulled me into a consulting engagement. They had started an internal incubator to diversify their business and come up with some new business concepts. And they had an idea around financial services, but they wanted us to create something new for them. So I did a consulting project while I was in school. We created an idea for a new business around consumer-directed healthcare. These were the very earliest days of consumer-directed healthcare, and presented to them, and they liked it, and they asked us to go build it. So that's what I did coming out of school, and that's how I fell into healthcare.
What a great start. So you came in, kind of had already funding, I guess, for your first startup out of the get-go. And then how did the path continue from there?
Yeah, so we had an idea to start, and we started WellPoint's first HSA product, actually, and then a series of lending products for consumers and providers around the high deductibles. And so the high deductible that goes along with the HSA product. And integrated it in with some of WellPoint's health plans. This was actually WellPoint before the Anthem merger. Mm-hmm. And so lived through the Anthem merger there in the early 2000s and started a new company called Arcus Financial Services that we put in Salt Lake City. Ran that for about 5 years, started a bank, the HSA product and the other products as well, and grew that pretty nicely throughout that entire process. And so got to see all of the ins and outs of the merger as well as starting this new business for them. And it really started a theme of my career, which is I sort of accidentally in the world of healthcare have fallen into the emerging trends in healthcare, sort of being at the forefront, in that case being consumer directed, and then shortly thereafter getting into value-based care.
I mean, it's interesting because in many spaces in healthcare, consumer-directed healthcare is kind of a pipe dream. But I think in your realm, kind of where insurance and personal finances meet the health plans, it actually is working and is happening. And it really feels like over time, consumers have been much more empowered, or patients have been more empowered to act as consumers, which really hasn't permeated in many other areas in healthcare. Why do you think it's caught on kind of on that concept of like the employee benefit plan and how it ties into our individual finances?
Well, I certainly think that the high deductible, that making consumers responsible for more of the early expenses each year does make them think more, obviously, about what are they spending, and around price transparency, around all of those movements in healthcare. Now, what I would say is, unfortunately, the idea behind the trend was that, well, this will help bring down these runaway healthcare costs in our country. And unfortunately, that has not happened, right? And so that's kind of another theme in my career, which is I seem to always be working on things to try to tackle the runaway costs in healthcare. At first, it was consumer directed, and then it was value-based care, which is then realign the provider incentives, right? Which is, of course, the world I've been in now and been in for a long time. We're all struggling to see that dent in the trend, but we're not giving up.
Well, I mean, we need more people like you that aren't giving up. Someone has to fight the windmills, and certainly it's one that's worth fighting. And yeah, so maybe let's talk about that transition from kind of consumer-directed care to value-based care. Similar idea, right? We try to increase the transparency. We try to make sure that the provider is on the hook as well for the cost and tie it to the outcome. How has that gone so far? I mean, that's also been a journey that's had kind of a pretty squirrely line.
Sure. Yeah. So I actually went to work for a company called Healthways, which was what I would call the OG of value-based care, population health. We called it disease management. And when I joined, we served employers and health plans because those were the two types of entities that were on the hook for the costs of healthcare. And we ran programs to work with patients to try to change their behavior, improve outcomes, and reduce costs, make them healthier. If they're healthier, then their medical bills are going to be lower, and you're going to help that trend. And that was a challenge as well, well-intentioned, but a challenge. But then shortly after me getting into that, the Affordable Care Act came out. All of these ACOs were created, and this shift toward, as you just referred, toward the realigning the incentives for providers. And that actually solved a big early problem in disease management, which was engagement, patient engagement. And now if you could get the provider involved, obviously patient engagement would go way up. And you also now had the ability to maybe make some changes to the provider behavior, to the physician behavior, to the health system behavior, in order to further affect change. Now, how has it worked? I think where it's happening, it has its impact. It's a fantastic thing, first of all, because the goal of improving outcomes, making patients healthier, and getting paid to keep patients healthy rather than treat them when they're sick, of course, is the right goal and has had positive impact. The challenge is simply that CMS, as much effort as they have made into advancing model after model, still has to live within the limitations of the current built environment, if you will. The enormous capital resources that have been deployed in healthcare. Think about the hospital systems. Think about the capital expenditures into these buildings, and into these units. Impacts how fast you can just completely shift the payment mechanism, the payment incentives. And so you really do have to sort of step into it. And so obviously, what you have today is you have many health systems with, you can use a lot of different analogies, but with a foot in two boats. Mm-hmm. They live in a fee-for-service world in many cases and in a value-based world in many cases. In one sense, have an incentive to perform surgeries and more surgeries, and in the other sense, have an incentive to limit surgeries. And so it's not that any one person is not well-intentioned. It's a challenge in the overall environment. But we are making incremental improvements. And at this point, I think that's all we can ask for.
No, and I agree. I see that. And maybe it varies also by disease state or by condition, which perhaps gives us an opportunity to unpack a bit of what you're doing at Livara, because I think it's interesting you've focused on a condition that is really geared towards keeping people out of the OR, right? Keeping people well and living longer and being more independent. And so if there's one area where I think prevention is making some inroads and kind of this idea of, outcomes driven medicine is having, a pretty substantial impact, it is in that field of MSK. Maybe talk to us about Livara. So you were kind of working across these multiple startups. The world was changing with the ACA. How did you come into Livara?
Sure. Well, most directly, a recruiter called me about the Livara opportunity. So it's kind of that simple. But I think the question is sort of what attracted me to it. Why did I come to Livara? And Livara was a very interesting entity to me when I took a look at it, and that had been around for a long time. We've been around for 17 years. Mm-hmm. Treating well over 100,000 patients in that time period with a clinical model that has evolved and been perfected over that time by our founders and by two spine surgeons were our founders, and really proven to make significant impacts on cost of care, on surgery avoidance, on reduction in opioid prescribing, and all sorts of really, really great metrics. Now, the way the company had been run is that there wasn't that much focus on growth, actually. So it was this small company just entering or just just on the having the potential to enter a real phase of growth, but with this clinical model that had really been well honed and proven through longitudinal, peer-reviewed, independent studies of tens of thousands of Medicare and commercial patients. And so I saw that and I said, wow, I think we really have something here. I think these days what you see maybe all too often is that early stage value-based care companies, they go get the client and then they figure out their clinical model. That's a dangerous thing to do. And what we had was a clinical model we had figured out, and now we had to go get more and more clients. We had some premier clients, but we had to go get more and more clients. And so I thought it was a great opportunity to come in and apply what I had learned at many other places and spread our model to many, many more lives.
So maybe take a moment, Rob, to help explain to our listeners how Livara works. And again, keep in mind, we have a lot of U.S. listeners that might be really in tune with, the value-based model and all the different actors, but also a lot of international, maybe non-U.S. listeners. So if you could just take a moment, just kind of the crux of how it all comes together in the context of working with health plans and with self-insured employers.
Sure. So we target two main groups, health plans and risk-bearing providers. Those are our two main customer segments. And for perhaps the non-US folks, what we mean by risk-bearing providers are those provider groups that take risk, that have responsibility for the cost of care. And so that way, both of those entities, health plans and those providers, have an incentive to lower the cost of care, right, and to do things a different way. And we can work a little bit differently depending upon the client, but essentially what we do is we act as the easy button for musculoskeletal care for either of those entities. And what I mean by that is any patient that or member that those entities encounter, whether it be a PCP through a patient walking in the door with an MSK complaint, or a health plan looking at their membership and seeing members that have MSK issues, they can just send them to us. They don't have to make a diagnosis. They don't have to figure out, well, do I think this patient needs physical therapy, or do they just need to go see an orthopedic surgeon, or do they just need an injection? They just send them to us. And then we take them in with some clinical information. We can immediately do some risk stratification based on what we know about them and some information that the patient provides to us. And then we connect them to one of our experts. And we have experts on staff all the way from an orthopedic surgeon to a physical medicine and rehabilitation doc, to a PT, to a certified athletic trainer. We have whoever a patient needs to speak to and that we can connect them to such that we can do a deeper consultation and assessment. And then we can really make a really good determination on what the right path for this patient is and create a care plan.
And why is that more cost effective though than a provider doing it themselves? I mean, they know the patient, they're in the community, they've got hands on the patient. How can you do that more effectively with your virtual kind of stratified specialist model?
Sure. So in the case of a PCP, for example, it's a lot to ask of a PCP to make a diagnosis of an MSK patient. For one thing, they're just not trained in it. Mm-hmm. They don't have that particular expertise. They're obviously also busy. And then oftentimes it may take multiple visits with a patient. And so sending them to us and us being able to connect them to the really expertly trained person that can really make that deep clinical determination just leads to getting to the right answer more quickly and also making sure that incentives are aligned.
And then how do you save costs for the health plan by avoiding unnecessary surgeries or kind of out of the gate finding the right tool for the job as opposed to having the patient, I guess, kick around between different referral patterns, imaging specialists, PCP, et cetera?
Sure. Certainly our number one area of cost savings is in avoiding unnecessary surgery. Yep. And that doesn't mean avoiding surgery. It means avoiding unnecessary surgery, right? I think that's the key point. There are also other types of procedures that we may avoid. We may avoid unnecessary MRIs if we determine one's really not needed. We may limit the number of injections because we deliver the appropriate PT along with an injection, where an injection is used to improve pain and then enable a person to undergo the right therapy they need rather than just relieving pain until the next injection, for example. And then in the cases of situations where people do need surgery, we do navigation. And so we will get people to the right surgeon in our eyes. We form a high-performing network, for example, in the markets that we're in. And then we match them with a surgeon who is an expert in exactly what they're dealing with, who may have the best outcomes, who may make the appropriate use of ambulatory surgery centers where appropriate, all of those types of things to ensure that we're optimizing the surgery if they are getting surgery.
Super. No, that's really helpful. And I'd love to come back to this whole point of value-based care, maybe what's working, and also reflect a little bit on how that exists in other models, like here in Canada. But we started with you. And so you kind of had this organic growth of a few roles where you had kind of grown in and built the company around you. And this one you sound like more parachuted in as a hired gun CEO to step in for the founder. And having done that also several times in my career, I know it's not easy. Tell us about that experience and what was it like taking over for the founders? Were you the first CEO that wasn't the founder?
There was an interim in the middle, but other than that, I was. One of our founders is our chief medical officer, and so he's a terrific guy, and so he's still around, kind of running our clinical models and bringing all of the learnings that he's had. But what I would say is the transition has been fantastic. I have a great team. Everyone involved was extremely supportive. And so you do hear sometimes those somewhat nightmare stories of taking over in those sort of situations, and I didn't face that at all. So fortunately, I was lucky in that regard. Now, obviously, anytime you come in, you bring your own opinion of things and your own a fresh set of eyes, and so we've made certain changes in different areas. But again, what everyone's simply been interested in is what's the right answer for the company. And that's what we've done. We've put in place what we believe is the right answer for the company. And I think we're starting to see the fruits of that labor.
How long ago did you come in?
I came in a little over a year ago.
Okay. So pretty fresh. Okay. Well, I mean, that's really positive for a year into the role. Certainly, it sounds also like the founders had the right mentality and the real desire for change, right? Because even if the company was doing great, when you bring someone from the outside, the intent is to shake things up, right? And that means that as a new CEO, almost every decision you make is a departure from a prior decision the founders had made, which you have to manage very thoughtfully.
You do, and very respectfully, and I bring the learnings that I have in the past from scaling health tech companies, digital health companies, tech-enabled services businesses, and bring everything that I've learned and seen others do that I believe is right, that I believe is maybe not the right path, and apply all of that to what I think is best for Livara. And so I think everyone realizes those are my intentions. It doesn't always mean that it's that easy, as you said. But our challenges are elsewhere. Fortunately, we have not faced many of those internally.
Good for you. Well, it's a testament to your founders and to you. And no question, big EQ quotient there has to be involved. And so it's been about 20 years since you made the shift into healthcare. My perspective is it's kind of a one-way door. Like it's very few people that come into healthcare and leave it, as tough as it is, right? It's like pushing a wet noodle up a hill. And yet I find it incredibly gratifying. What do you think? Are you hooked for life in this?
Yeah, I'm totally on board with that. The door does not swing the other way. And I think that's for a variety of reasons. One thing is, you just get into these mission-oriented companies where you're pursuing something that's, really, I think, noble and really trying to help people. And it's tough to then go back to doing something else that maybe doesn't have some of those characteristics. At the same time, what I would say is also it's such a challenging industry, and certainly U.S. healthcare, that has so many nuances to it, that once you learn it, you don't really want to give up your ability to apply that. It's too valuable.
Yeah,
right.
Your domain knowledge is so hard, like all the pain you've been through and understanding how health plans and providers and patients and employers all work is like, it's a world in of itself, and very few people have that knowledge.
Exactly. And so there's a lot of value in having it. And so you tend to stay in it rather than jumping to something else where it has fewer, almost barriers to entry, you could say. There's a barrier to entry because you understand these things to such a high degree. Yeah.
Okay, well, let's come back to kind of our main topic of disruption through value-based care. And I think you made a good case on why it works well in the context of MSK. And it sounds like you've really curated this very thoughtful process where you have a lot of continuity of care. You've got a team of clinicians that range kind of from different skill levels and different expertise levels to help kind of that single point of access for the patient to manage their condition. Is there a role for technology to play? I just asked that because a lot of our audience are medtech entrepreneurs, and it sounds like a lot of what you've accomplished is a little bit more kind of just common sense sneakernet of like people working together as individuals. But what role does technology play? And maybe how have you applied that in your role?
Sure. Well, there's a heavy technology component. First of all, on the analytics side of things, the data and analytics side of things, certainly as we bring patients in, as we look at their clinical data, we've been serving patients for so long that we can then risk stratify based on all of that data and all of that information from what we've learned in the past. Some of the models that we have to understand what the right path of a patient is.
And it's basically like outcomes data, Rob, like, kind of we did these series of steps and it led to this outcome. And therefore I've got a population base to say, hey, I think this is going to work for this new patient coming in the door because they've got a similar history, similar indications, and I'm confident that this outcome could be achieved.
Correct. And we can also look at certain things that say it used to be believed that with this type of condition, surgery was the only path, but we know from our experience and what we've done that actually, if you apply these techniques instead, that they can be highly effective.
Mm-hmm.
And so there's a variety of ways in which we can use that. So that's one layer of it. Two is we do provide a virtual program. So we have a virtual physical therapy home exercise program that is obviously technology based through our app that patients log into. We also have a set of psychosocial interventions in the app as well. So we are strong believers that in that holistic care, certainly when it comes to MSK and the huge impact of nutrition and mindfulness and sleep and pain psychology and the links between depression and musculoskeletal issues are well documented. And so there's a lot of that that we try to address within our program. So that's all. It's not all digital. There are people involved as well, but there's a heavy digital component to it. And we continue to bring more and more technology to that. For example, computer vision, right, to the virtual home exercise program where it's sort of following your movements and giving you real-time corrections, right, based on AI and machine learning and so on and so forth. So there's certainly that layer to it. And then go ahead.
Well, just on the app, I mean, so that's kind of a digital therapeutic, basically, of kind of trying to drive the therapy from digital engagement, whether it's physical, move this way, do this exercise, or app will help track if you're doing it right, and then kind of social, emotional engagement, sleep, food, all that. That's the idea. Is basically the app is helping you to get to the outcome that you're working towards.
Correct. And that app still has coaching associated with it. From a certified athletic trainer that is working with those patients to make sure they're on the right track, to make sure we're adjusting the exercises when they need to be adjusted. And then finally, we have our navigation, right, which is another application of the data and analytics that I referenced, right? So who are the right clinicians to be referring to? What are the right places to go? All of those sorts of things.
That basically gives that kind of one-stop shop for the individual through the app to understand how to get the referral to that specialist and how to find their office and know what's coming next in the process for them. Is that right?
Correct.
Yeah.
Correct.
On the digital therapeutics, I'm interested because also as an investor in medtech, I want to say 2020, 2021, like you're getting all these SPACs, crazy valuations, kind of, it really felt like digital therapeutics were going to replace so many molecular therapies or physical therapies that we were doing. And kind of this thing in your pocket, this app was really going to change your healthcare disposition. Yeah. It didn't stick in most spaces. Maybe diabetes care is one, MSK is another. What's your perspective on that as an alternative to physical care and maybe what made it successful in the MSK space?
Yeah, I think it is a little bit unique versus some other digital therapeutics that were out there. What we're really talking about doing in this case anyway is replicating what has historically been an in-person intervention, right, in a physical therapy clinic, for example, but allowing you to do it at home, guided by technology, right? And so you're still doing the exercises, It's just you're able to do it at home at your convenience, at your pace, and guided by this digital intervention. Now, I think over time, what we may see is that we're able to bring even more sophistication to it, using more artificial intelligence, using more automation, and those sorts of things. But that's really what you're doing in this case. Now, we don't believe that it's appropriate all the time. So we also, there are times when we believe hybrid is the right answer. And when that happens, we actually prescribe that for our patients. And what it'll be a hybrid in-person and digital experience, where we believe they do need to see someone for a limited number of visits sometimes, for more visits other times, because there's certain things going on with that patient that they just actually need a physical therapist to put their hands on them and intervene with them in some way. And we can enable that at home. We can enable it in a clinic, and it's well coordinated then with the digital intervention.
Got it.
Yeah.
Yeah, I mean, it strikes me that this whole space is one that, patient engagement is relatively high in. Like, you just observe people, go out of their way, book their own preventative physical therapy or massage or chiro or RMT sessions. If you told me that I had to go see my cardiologist to, oversee my CHF, I'd probably be a lot less adherent than on the kind of physical therapy side, which is just interesting. And, kind of this whole kind of allied health element has been really, I think, generally successful in high engagement from patients. Do you have a view on why that is? Especially given that you've seen a variety of different disease states and conditions you've managed kind of in this intersection of consumers and healthcare.
Yeah, it's a really good observation. When you think about companies like ours, the patient enrollment and patient engagement is always a huge challenge. And right, your intervention can be the best in the world, but if no one's using it, it's not accomplishing much, right? So obviously that's the first step, and you've got to make sure that's high. And I do think we have a bit of an advantage over other disease states. If you think about, you referenced diabetes, some metabolic syndrome. Oftentimes the impact of someone having diabetes is not seen for years, right? And so you're trying to get someone to change their behavior on a somewhat invisible condition, just because if they eat high sugary foods, or they're not at the BMI they need to be at, or they're not exercising as they should, they don't feel any different today than if they did change their behavior, generally speaking. In our case, though, a lot of times the person is in pain, right? They're either in pain, or they're unable to play the pickleball that they want to be playing, or they're unable to be doing something. And so they have a need, and they are looking for help. And so we are offering them help. And even in particular with our solution, what you'll often find today is if someone refers you, if a physician or someone else refers you to an orthopedic surgeon, you might get an appointment in a couple of months, right? If they refer you to PT, even today, the wait times to get into a physical therapy clinic are growing and growing and growing. It could be a month away or a few weeks away. And we're able to offer, a consultation within 48 hours and immediately getting involved in the program. And so even if a person just decides, I still think I would need to go see someone in person, because that's just the way I think, but I might as well give this a shot while I'm waiting for the month that I don't have, until my appointment. And so I do think we have some built-in engagement advantages.
Yeah, it's interesting as you describing your business, I can really see that the consumer orientation is so deeply embedded in how you think. And I know you used to work for Disney, that's also a company that's really famous for strong consumer orientation. Maybe this model that you have where you're kind of part care navigator, part provider yourself, with a patient being treated as a consumer is what's getting that high engagement. If we could replicate that to other areas, even again for much more medical conditions like, diabetes, congestive heart failure, metabolic syndrome. But if we thought about treating those patients as consumers, not as patients, maybe we could achieve outcomes that are more similar to what you're experiencing.
Yeah, and I think you see it in a lot of different areas of healthcare. A growing focus on consumers. If you think about other companies, really thinking about tackling patients as consumers. And if you look at us internally, even the way we're organized, we have, product that is consumer focused and product that is clinician focused, even for our own products, right? Because we have clinicians. And so we have to have a product experience that our clinicians want to be using. And of course, our partners' clinicians want to be using to the extent they're using it. And then we have a totally separate team that is thinking patient, patient, patient as consumer, consumer, consumer. How do we engage them? What do they want to be seeing? What do they want to be using? And so that's exactly right. It's exactly how you have to be thinking.
Yeah, maybe I can pick your brain. I'd say, both for my company and a lot of med tech entrepreneurs that I talk to, we're traditionally, you build your business as a B2B business selling into the provider world. And we're often thinking, oh, there could be an application in the consumer world, but it kind of feels like our DNA as a company isn't a fit. We know how to sell to providers. We know how to sell to people in white lab coats, how to market to them, how to serve them. And it sounds like you tackled that by having essentially kind of a separate team, recognizing that a B2C product, a B2C service is quite different.
We do. Now, I would say the number one challenge, in my opinion, still remains in healthcare, which we're not facing right now, which is that consumers are not wired to pay for their healthcare, not traditionally, right? And so we are not asking consumers to pay to use our service because our partners pay for it. It is free of charge to the consumer. So we're thinking about the consumer experience. But to the extent that healthcare companies are thinking about, let me go sell something to consumers, that is a different ballgame because they are not traditionally, while they're used to having insurance, everything is supposed to be covered. Right? Yes, they may have their deductible or a copay, but everything is supposed to be covered. And why should I have to pay for my healthcare? It's just kind of the way that people have been trained to think. And so that is the most difficult task of, quote, sort of B2C healthcare, if you want to call it that, which is, will someone pay for my service?
Even though kind of spanning that medical and allied health domains maybe makes it a little bit easier. I can say from our experience here in Canada, where we have, a public health system principally, or more so at least than in the US, people are really geared to exactly how you described. If you tell them, oh, you have to pay $150 for massage therapy, they wouldn't blink. They wouldn't think twice because we kind of know allied health. Well, it's either covered by the health plan or out of pocket, but whatever. I'm kind of used to giving a credit card. If you told them, you could get a life-changing surgery 9 months earlier, but you have to pay for a copay that's maybe even equivalent to what you had to pay for your massage therapy, they'd say, forget it. Healthcare is national. I'm entitled to get that. I will wait my 9 months and do it smiling because it's public, right? That's kind of the approach that I think much of the world has. And again, maybe by straddling some of that allied health domain where we have, been conditioned maybe as to think a little bit more as consumers, we can see a little bit of a faster breakthrough. I appreciate that you're still funded by health plans, not for people out of pocket, but it's in an area that's not foreign to them to think that a credit card could be involved.
I would agree with you. Yeah. The closer you get to a massage, a spa experience, the more likely they probably are to pay for it. I would agree with that. Yeah.
Mhm.
Yeah.
We in ultrasound get a sell principally to providers, and with handheld ultrasound, with the use of AI, we've really lowered the hurdle rate substantially in terms of the ease of use, right? So we, in terms of our FDA clearance, we can serve any licensed healthcare practitioner. That could be a nurse, it could be a midwife. So kind of continue to lower the scope of practice of individuals that are able to use ultrasound. It's not inconceivable that ultimately you'll be able to convince the FDA that it's safe and effective for a patient to use. But can we get to a commercial model that a patient says, I'll give you the example of OB. It's a good one because I don't know if you have kids. I have 3, and I can tell you that we've had moments where my wife said, honey, the baby is not kicking. We got to go to the ER. I got to see that everything's okay. Right. And of course, they strap you to a heart rate monitor and have a quick ultrasound and say, ma'am, your baby's fine. Now, that's about 26% of all ER visits during pregnancies are false alarms. You could think that in that space, individuals say, I will rent an ultrasound. Let's pretend that there's an AI-powered, FDA-cleared ultrasound for the course of my pregnancy to monitor my pregnancy. Could we get patients to pay? I'm not sure. Maybe babies are kind of one area that's a little closer to that consumer experience, that spa experience, that maybe could break through. I think for CHF, where also you could use ultrasound at home to measure your interstitial lung fluid, and as an alternative to an electronic scale, I think it'd be a lot tougher to convince patients to get out their credit card for that.
Agree. One of my daughters had a million ear infections. And so every time she would cry, you didn't know if she had an ear infection. Right. And you're running to the pediatrician every time, check her ears. If at the time, now they do, but if at the time I'd had a scope at home that I could have used that could have put in your ear, I would have paid a lot for that. Yes. So you're right. There are certain applications. Yeah, absolutely.
Super. So, I mean, in terms of state of the union, it sounds like you laid out a model, a blueprint that is pretty successful, right? Of kind of convergence of kind of full medical conditions and procedures integrated with allied health services, straddling both care navigation and care delivery, and are delivering good results in avoidance of unnecessary procedures, kind of finding the right tool for the right need of that patient. How do we extrapolate that maybe then more broadly? Like if it's been successful in one area, as we look ahead, and this podcast is often a lot about disruption, how can we change kind of the tepid, the glacial pace almost that the adoption of value-based care is taking place? What would be your call to action? How could we accelerate this, maybe leveraging what you've learned and the successes you've had in your company?
Sure. Well, if you're going to accelerate the pace of value-based care, I think it really is more about the payment models than the delivery models or the care models. And so the first thing is you just have to keep pushing forward with the new models like CMS does. They introduce new models every year, but continue to do it. And quite frankly, you've got to continue to get a little bit more aggressive about it. If you really want to make the shift, then you've got to make it less lucrative to do procedures and more lucrative to not do procedures, right? And I think as we do more and more of that, then there's more incentive for entities, provider groups, whoever it may be, to get involved in these models and then to either do things on their own or hire companies like ours to help them with it. And so I think from that perspective, you've got to continue to push those along really, really quickly. Now on the actually sort of performing in those models and optimizing the performance within those models, I think there are a variety of ways to do it. One is the continued advancement of just the continued use of virtual care, just make things so much more convenient for people and cheaper to deliver in many cases. So that's one area. Second area is technology, the continued advancement. And the more automation we can do, so much of what we're doing, to circle back to the discussion about patient engagement, so much of what we do is making sure we are staying connected to the patient, engaged with the patient,
Right.
on making sure they understand what's going on, the conditions. Of course, not going to the ER if they don't need to go to the ER, interacting with us or whatever it may be. And so it's obviously very expensive to try and engage very frequently with the patient using people. It's obviously less expensive if you can do it with technology. And if you can do it in a highly engaging way, replicating a human experience, but with technology, through the use of large language models and all of the sort of advancement of Gen AI and so on and so forth, then those can be really, really important in order to identify what's going on with people, reach out, make sure they're okay, intervene if they're not okay, right? Mm-hmm. So I think that's a big area that we need to continue to push forward. So I think if you look at those two things, and then in terms of, circling back to that virtual, really one big impediment or hurdle to the virtual continue to be a lot of the licensing laws, within the US, the state by state licensing. And for companies like ours, and there are a lot of them, it's expensive and it's arduous.
In terms of who's allowed to practice to consult remotely for a patient here versus there.
Exactly. In what state? Where is the patient? Do we have the proper license? Who do I match them with? I can only match them with this clinician on my team because they're licensed in that state and this one isn't, and all of that. If we could break down those and start to see some continued progress there, then that would be important.
Super. Well, I mean, those are three really tangible points. I heard one is alignment of payment models continuing to drive shared incentives between the payer and the provider, and seems like they are becoming one. Second is to really think about engagement and the role technology can play, so we can mimic more like the kind of engagement we have in many other consumer spaces where we're used to being touched frequently versus kind of the sometimes just disjointed contact we've had with the healthcare system that kind of ebbs and flows in very like acute peaks and valleys. So more consistent, and again, using technology to do that at a level that's affordable and that's maybe also comfortable now that we as individuals are so conditioned to work with technology. And then third is addressing, in order to really unlock more of the potential of virtual care, addressing the challenges of licenses and ensuring that we can have more cohesion with the ability to serve with clinicians and patients in different jurisdictions. And again, it has to be done safely, but I'm sure there's more top-down ways to align that than kind of the bottom-up approach of every state or county or medical board doing it themselves.
Right. Yeah, absolutely.
Well, I learned a lot today. And again, I'm really impressed with what your company's doing. I mean, I'm so glad there's companies out there that are really tackling those windmills. And it sounds like having some success. It's not easy being Don Quixote, but I'm glad there's people like you out there. Just before we close, if our audience want to learn a little bit more about you and what you're doing or your company, where can they go for more information?
Sure. Well, we always have a website, livarahealth.com, www.livarahealth.com. We have a LinkedIn presence, Livara Health. Those are probably the two best ways.
Super. That's really helpful. And yeah, I just want to say, Rob, I really appreciate you coming out, spending time with us today. I learned a lot.
Well, thank you. I appreciate it. Enjoy the conversation.
Excellent. And then to all of our listeners, please make sure to join us for another episode of our podcast coming soon. That's a wrap.